Good morning, everyone. I'm Dr. Joy Lego from Usman Danfodio University Teaching Hospital. Currently working at the neurology unit. I'll be taking us this morning on examination of a child with movement disorder. Pediatric movement disorders encompass a wide range of neurological conditions that affect the child's ability to control movements. Most of the time, when we see patients in neurology clinic, they have either a primary or maybe a comorbidity as movement disorder, but not much attention is paid to them. For example, a child who comes with epilepsy or global developmental delay, that usually is the focus. And most times, the movement disorder goes unnoticed. It's an evolving subspecialty in pediatric neurology, not really fully established in Nigeria. Most of them, in most cases, there will be hyperkinetic movement disorder, especially in children, and the hypokinetic movement disorder predominates, which is more common with adults. The neurons in the basal ganglia are very vulnerable to metal deposition, lysosomal storage disorders, and disorders affecting energy metabolism, all encompassing as inborn errors of metabolism. These disorders have a significant impact on a child's physical, cognitive, and emotional development. And it also requires a multidisciplinary care. The diagram of the basal ganglia, which is constitutes the caudate nucleus, the globus pallidus, putamen, and then some other supporting structures. It's most implicated in the pathophysiology of movement disorder. On the other side is the cycle of dopamine. So there's a strong evidence that movement disorder arises from the dysfunction of either basal ganglia or cerebral circuitry. These networks operate relatively independent, but are also still intertwined, although connections have been identified and may be pathologically relevant. What is peculiar about examining a child with movement disorder? Most emphasis is on the examination of the coordination, the heredogram, which is commonly called the family tree. Almost always you have to take a video of the child. Most of the studies and the validation of some of the tools have used videos to send to researchers to analyze and come up with conclusions. So there's Juan et al. Is someone in 2023 that came up with an easy-to-use tool for screening of children. So this is applicable. It is very simple and very short, not time-consuming, and a nurse or a medical personnel, even family physicians, can use it to screen children so that they can properly refer these children to these required specialists. So children with neurological conditions are usually treated by many different specialists, psychiatrists, family physician, and ophthalmologists. And the issue is that because a lot of people are not familiar with diagnosing movement disorder, and the fact that they usually occur most of the time in combination, it makes classification difficult. Juan et al. In 2023 developed an easy-to-use clinical tool, usually for children above 4 years, which was able to detect moderate to severe movement disorder. For above 4 years, because the child has to be able to obey command. And then because most of these researchers were sent the videos and did not see these patients in person, it was difficult to actually identify whether the mild forms of movement disorder. This tool can contribute to enhanced clinical diagnosis. It's very quick and fast, and improve the quality of life of children affected. It screens for the presence of movement disorder in general, so it is not very specific for the specific subtypes of movement disorders. It was able to identify 80% of patients in the study, and in the inter-rater agreement on the presence of moderate or severe movement disorder was very good. Like earlier said, the distinctions between no movement disorder and mild movement disorder seem to be more difficult because most of them did not see these patients in person. It was videos that they used to assess the children. It enhances clinical diagnosis and improvement in quality of life through recognition of movement disorder, and it can be used by even parents. So the first question to ask when you're confronted with abnormal movement in a child is it a movement disorder? The next one is, if yes, then what to classify the movement disorder phenotype and which is most predominant? Because you have things like myoclonic dystonia and chorea in combination with another one. So you will have to identify which one is most predominant and which one is the second predominant. That will determine the management and how the treatment is instituted. And could it be could the movement disorder be a functional one? The functional movement disorders have psychological base, and by way of investigation, you don't find any pathology, but and then there is really no pharmacological treatment except for behavioral therapy, cognitive behavioral therapy. So you need to determine the clinical syndrome. Is it ataxia telangiectasia? Is it a genetic syndrome? Can this movement disorder be caused by an acquired cause? And does this clinical syndrome fit a treatable inborn error of metabolism? And the symptomatology of inborn errors of metabolism from neonatal age to childhood is usually very prominent. And in that case, you consider genetic testing or next generation sequencing phenotyping. And this is a simple tool that Kaon and his colleagues came up with. It simply means observing the patients with arms at rest, slightly in prone position, and observe for some seconds and see if you can find any abnormal movement. And the child raises their hands up and flexes the fist, and then uses the two index fingers and oppose against itself, and you would see if there's any abnormal movement or overshoot. So the question now you ask is that, is there an abnormal posture of the arms or hands? Is there an abnormal movement of the arms and hands? And so you also assess the patient with writing, usually writing their names, repeating a sentence several times, or the one that is really has come into limelight and is commonly used is drawing spirals. So the examiner draws a spiral and you ask the child to trace the spiral. There is a challenge with environments where children are not educated, do not write, do not go to school. So, but I think tracing a spiral should be simple enough. So you observe the patient while the patient is drawing a spiral with both hands. So if you want to start with the left or you want to start with the right, one at a time. And then you do a finger to nose test. And so you'll be able to see if there's an abnormal grip of the pen or increased pressure while writing. Are there involuntary movements in any of the two hands? Does the spiral contain irregularities? And is there an under or overshoot? Or is there a tremor? And so I'll be playing the first video. And the first video has to do with taking consent, assessing hand movement in a girl with abnormal neurological findings. And the second video is taking consent, assessing speech and swallowing and walking in a 13-year-old boy whose neurological examination is normal. So Hafsa, good morning. How are you? The examiner is taking consent from the mother and the child. Just some things. I'm not going to stress you much. Yeah, just for some few seconds. Are you okay with that? You could see some obvious tremor on your right hand. And even when she stretches her hands, the tremor is more on the right hand. Still obvious on the right hand. Touch my hand, touch your nose. So we're going to do the finger nose test. Now to see the obvious fast pointing. Also, good times. And quite straightforward on the left compared to the right. Which is going to trace the spiral with a red biro so that it's very obvious. And then you could see the obvious shaking of the hand and irregularity of the spiral. And then she's walking very, very unsteady gait, falling by the side. She's finding it difficult to do the tandem walk. She's trying to walk on the heel, which is really, really difficult for her. And this heel toe is supposed to accentuate the whatever movement disorder is present. And it's really important to expose the children maximally. The shoes off, maybe a boxer or a very short trouser, and if possible, where possible, even including the shirt is removed so that some other abnormal movements can be observed. Now we're going to the 13-year-old boy who been assessed for taking consent from the mother. So from the speech, we're able to assess the quality, the characteristic of the speech. Sometimes you have some dysphonia, spasmodic movements, but in this child, he is neurologically okay. We are not pathologists. So he's meant to repeat some words, protrude the tongue, or any abnormal movements. Observe the face if there are myoclonians, nystagmus, some other. It's meant to do repeat blinking, 10 times, one side after the other. Trichopolis is usually quite obvious as the child is coming to the examining room, but we are still assessing the neck. So this child is maximally exposed. He was wearing a long trouser which was actually pulled off. He's doing the tandem walk. Other times you can actually tell the child to move backwards, which helps accentuate whatever movement is already done. If we observe the child standing still, tapping the leg, high, both high and low tap. Sometimes you check for full test to make sure that the child can regain balance after a very short stimulus. Go back to the presentation. So this was a writing. It was a writing of the girl. You could see that the left side is really different from the right side. You could see some irregularities. You could see that some are getting out of the border from at the left hand side, which is really quite is fairly regular. I would ask her to write 1 to 10. She could only write with she could write with her right hand, but really there were a lot of movements, and that was her name. There are situations where you ask the patient to write repeatedly the same thing over and over again, and on the left hand side you could say Mary had a lamb, and the person kept writing it until you could see some irregularities, and at some point nothing written, which is typically seen in writer's cramp. And then on the right hand side is a very irregular writing. Mary had a lamp with a spiral and with a lot of irregularities before treatment, and the one tagged 24th of August is really relatively smooth. That's after the treatment. So writing can actually be used to test hand movements in movement disorders. We saw both children walked. The first one was for the boy, it was quite easy, the tandem walk, and for the girl, it was irregular. And then the arm length swing was at some point was very not equal on both sides. And there was abnormal posturing of the body, some difficulty in turning. There was a lot of staggering, and the patient needed support. Like earlier said, it is important to expose the patient maximally so that both the spine, the legs, and the hands are seen properly. By way of history taking, the presenting complaints could either be hyper or hypokinetic movements. The hyperkinetic movements constitute dystonia, which is actually a spasmodic pattern, repetitive or sustained full contraction of both agonist and antagonist muscles, leading to abnormal twisting and movement of postures. Chorea, it is an involuntary irregular muscle and unpredictable movements, usually dance-like, affecting various parts of the body. Ataxia is an inability to coordinate voluntary muscular movement. Myoclonus can be a form of epilepsy or a form of movement disorder, which is jerky-like muscle movements. Spasticity is an increase in voluntary velocity-dependent muscle tone. And tremor, involuntary rhythmic but oscillatory movement of any part of the body. There is also dyskinesia, involuntary erratic rotating movement of the body. And there are other many conditions, which a few has been listed here. There's a sleep-related movement disorder, which is restless leg syndrome, periodic leg movements, sleep bruxism, grinding of the teeth, benign neonatal sleep myoclonus, or the infantile type. And you have others, aphasia, inner sense of restlessness, and in case of restless leg movement, it's the legs that majorly move, and this, in this case, seem to be the whole body. So these are examples of torticollis and their names and their positioning, the lateral, the ante, retro, and then the other types too. For the hypokinetic movement disorder, you have bradykinesia or akinesia, difficulty initiating and slow in executing movement, which is seen in Parkinson's or Parkinson-like disorders. The restless leg syndrome is an irresistible urge to move the legs, typically in the evening or while on bed. And there's another one I saw when I was doing my fellowship, which is an interesting disorder called the mirror movement, where both an action initiated by one hand is replicated simultaneously on the other hand involuntarily. So it's an involuntary movement that occurs on one side of the body in sync. So if the child is writing with one hand, automatically the other hand begins to write too. And sometimes they have to control it by putting the hand below their thigh, so that they usually have difficulties, but usually with therapy, some are able to write considerably. We have the sleep bruxism and the hypomania, which is the expressionless face you see in Parkinson's disease, myokemia, involuntary, spontaneous, localized quivering of the eyelids, tics, a compulsory repetitive movements or sounds that is often difficult to control, even though it's suppressible, and also Tourette syndrome. And then these are classifications of the movement disorder. You have dystonia. It can be classified in various forms, either primary, secondary, segmental, by way of anatomy, segmental, multifocal, hemidystonia. Generalized dystonia, it can be by body parts, oropharyngeal, oculogyri, and examples of causes can be genetic, DYT1, we have DYT2, DYT3, where genetic studies is available, and cerebrovascular accidents, infections, autoimmune diseases, metabolic, dystonia plus, which is usually alcohol or dopa sensitive, and then drug-induced, which we are going to talk about later. Chorea can be classified as atetosis, choreatetosis, Balism, Balism, and usually the most common we see is Indian chorea. There is also the juvenile type variant of Huntington's disease, benign hereditary chorea, and Wilson's disease. Myoclonic, but it is a challenge diagnosing these conditions because we don't have the facilities, the laboratory facilities, biochemistry or genetic studies to really accurately diagnose these disease conditions. You have a myoclonus, which the EMG can differentiate into cortical or subcortical, spinal or peripheral, local, generalized, and myoclonus can be physiological, epileptic, and histro and sporadic, idiopathic. And you have spasticity according to the body parts, the number of body parts affected, and then it can happen in stroke, cerebral palsy, hereditary spastic paraplegia. You will now have the ataxia, and the common ones we know are Fredrickson's, ataxia telangiectasia, and spinocerebellar ataxia, ataxia with vitamin E deficiency, glucose transporter type 1 deficiency, which I saw a lot over there, and the tremors, which was displayed in the girl in the video. It can be physiologic, hypoglycemia, anxiety can cause tremors. Then you have the ones that are drug-induced, and endocrine pathologies also. Dyskinesias can be bradykinesia, hyperkinesia, tardive dyskinesia, a common complication of antipsychotic drugs. The sleep-related movements, which were mentioned earlier on, other ones like mirror movements, blepharospasm, spasms, stereotypies, hypomania, tics and Tourette syndrome. So in the history, you want to know whether this movement disorder is hyperkinetic or hypokinetic. You want to know the most prominent one and the second most prominent one. What is the course and trajectory? Is it static? Is it progressive? Does it progress and plateaus? Or it is erratic, or the course and trajectory is not known? By way of variation, is it permanent? Does it wax or wane, or is paroxysmal? Is there diurnal fluctuation or not? And then assessing tremor, you have the handwriting, the spirals, and the straight lines, which were depicted in some way. Another one that was not on the video is using 2 cups, one filled with water, and making the child pour the water into the empty cup repeatedly, and then pour it into another empty cup. Just repeatedly, you'll see the obvious tremors. Then we are going to talk about the drug-induced movement disorders, which are usually extrapyramidal side effects. And the commonest is tardive dyskinesias. You have acute dystonic reactions, which is very common in pediatrics, especially when parents go to the chemist for medications. Akathisia, drug-induced Parkinsonism, which will be seen in pediatric age groups, neuroleptic malignant syndrome, serotonin syndrome, and drug-induced tremor. And so these are the drug-induced movement disorder, Parkinsonism, Rabbit syndrome, and you have the phenotypes, the risk factors, the prognosis, and how to treat them. And below, you have a tardive dyskinesia, acute ataxia, tardive ataxia, and then neuroleptic malignant syndrome. These are some of the example of drugs, the high risk, the medium risk, and the low risk. We commonly see children in emergency pediatric units who who have been given antiemetic like metoclopramide with some of these, and then we commonly prescribe risperidone, and then you have promethazine. So these are some of the drugs that are implicated and present as extrapyramidal side effects. And video is really very important when assessing a child with movement disorder. It helps to really characterize the movement disorder. And sometimes some of them typically disappear when the child is asleep. So, like depicted in the video, the first thing to ask for is a consent from the parents, and remove glasses, shoes, and clothes as much as possible. And the patient rests and sits for at least 15 minutes, head to toe. You observe the patient. Then you observe the speech, which was depicted in the video, and then the head and neck, the eye movements, and the neck movements also. All right, so we also have the hands, which was also recorded. What she didn't do was the pincer tap continuously, and then the marionette, pronation, supination, and then you could see the obvious pathology when she was walking, and the boy had no pathologies. So a study done by many researchers identify by order of priority, or the commonest one, in major different body parts of the neurological examination that can contribute to identification of movement disorders. And they realized that the arms contributed majorly to detecting movement disorders, followed by walking, writing, eyes, and the list was stimulus and bloods. Neurological examination constitute reflexes, rigidity, cerebellar signs, and pyramidal signs. So functional movement disorder is another interesting entity. I saw a lot over there, and usually the children are older, between teenage age, especially the late teenage age, and adulthood, early adulthood. This condition is difficult to diagnose and may cause marked disability. and diagnostic dilemma. These are patients where MRI is done, biochemistry studies are done, neurophysiological examinations are done, and majorly there is no identifiable pathology. Most investigations do not yield any positive outcome since it is psychological in origin. Usually diagnosed by psychiatrists and other related specialists, they usually can remember the day it started and the manner in which it started. But again, there is also inconsistency in symptoms and signs. You see them 2 months after, they have a different baggage of signs and symptoms another time. So it varies. There's usually an underlying stress, marital disharmony, stress, maybe they feel the cause, maybe there's depression, or maybe a tragic incident. And then the prognosis is really poor, but cognitive behavioral therapy may be useful. So, obstetric history, you ask about complications during pregnancy, miscarriages, or neonatal deaths, especially inborn errors of metabolism, chromosomal abnormalities, congenital malformations. Family history is really very important because a majority of if movement disorders are familiar. Some of them you can have acquired ones too. And that is why a family tree is very important in movement disorder. Most of them may run in the family, genetic mutations, neurometabolic diseases, mitochondrial disorders, neuropsychiatry, like Tourette syndrome. Environmental influences like exposure to toxin, trace elements, and infections can also cause movement disorder. So neurology is a specialty where you use a lot of scales, especially in movement disorder. So some of these scales you'll find in the website of Movement Disorder Society. You have dystonia, for dystonia, Barry-Albright dystonia scales, rating scales for psychogenic movement disorders, unified dyskinesia rating scales, unified chorea rating scales, Brook spasms, disability index, and many, many more which have not been validated in our population. Movement disorder usually have comorbidities like attention deficit, and these are the scales we can use to assess the comorbidities, the autistic spectrum disorder, obsessive compulsive disorders, sleep disorders, tics, self-injurious behaviors, and spasticity. So you have all these scales that you can use to really categorize and create and assess some of these comorbidities. By way of investigations, the slit lamp, especially in Wilson's disease, imaging, a lot of images, including DAT scan, which is not readily available in Nigeria, and functional MRIs, which are very, very good with basal ganglia pathologies, electrophysiological tests, electromyography, nerve conduction tests, accelerometry, and alpha fetoprotein immunoglobulins, biochemistry like copper studies, lactate, pyruvate, and all the inborn errors of assessing the inborn errors of metabolism, the CSF analysis. We could have biopsies of muscles, liver, genetic studies, and also a levodopa trial for dopa responsive movement disorders. I saw them use this a lot. It is called, this picture on the screen is called duodopa pump, and usually a way of an automated way of intermittently in a pulsatile form delivering duodopa into the duodenum, and it has, I saw it have a remarkable effect on patients, especially with Parkinsonism. So the first thing you ask the patient, if the movement disorder is not so troublesome, can they live with it? Not everybody, especially when they are mild, you could have conservative management. So you just keep giving the patient follow-up and nothing really is done. If they say it is something they can cope with their everyday life. And then cognitive behavioral therapy is something that is really, really becoming the foremost modality when it comes to treating neurodevelopmental disorders and movement disorders. The physical therapy, by way of pharmacology, you have the anticholinergic, the benzodiazepines, baclofen, either oral or intrathecal, dopaminergic agents, dopaminergic antagonists, and anticonvulsants are really, really useful when it comes to treating movement disorder. Botulinum toxin injection is something that was commonly given with very, very remarkable response, although the cost of it may not really be visible in our own setting. Iron supplements like oral iron, especially because iron is really implicated in pathology of restless leg syndrome, and then pump like Duodopa and deep brain stimulation. The place I trained was a center of excellence for deep brain stimulation and for dystonias or movement disorders, which are now available to cognitive behavioral therapy or pharmacology or Duodopa. There's an insertion of electrodes into the brain down to the basal ganglia. And then there's another one that comes to the chest, and the patient is able to control it with a tablet by so you can regulate all the parameters there. By way of conclusion, pediatric movement disorders are diverse and require a comprehensive disciplinary approach for diagnosis and management. Early intervention is key to improving outcomes. The news is not all bad. They are really, really treatable movement disorders that can give really, really remarkable response. Addressing challenges in low resource settings is crucial for better global care. And these are associations that I trained under: the European Society for Tourette Syndrome, the Global Tourette, Tics and Tourette Association, and a lot of resources can be found on the website for the International Parkinson and Movement Disorder Society. Thank you very much. These are my references.